Hello students, welcome to EPG Pathshala. I am Dr. Renu Tyagi from Sardar Patel Institute of Economic and Social Research, Ahmedabad. Today we will learn about the module National Health Policy, a historical review under the paper Physiological Anthropology. Now let's see what are the main objectives of our module. Through this module, we will be able to understand the evolution and development of the National Health Policy. Besides, we will be able to understand the recommendations given by the different committees constituted to frame the National Health Policy. And then in this module, we will be able to study the provisions made under the National Health Policies, that is National Health Policy 1983 and the policy in 2002. Every state must have a health policy to guide the state to make their proper health provisions of its citizens. But in the case of India, the health policy was very much delayed as the first national health policy in India was adopted in the year of 1983. Before the launch of this national health policy, several committees were framed to give their recommendations. Some of these committees were framed even before our independence, such as the Subcommittee on the Health Policies under National Planning Committee and the Bhor Committee. The different committees formed on the health before the first National Health Policy came in existence or will be discussed in the forthcoming part of this module. For example, the Bhor Committee 1946, the Mudaliar Committee 1959, the Chadha Committee 1963, Mukherjee Committee in 1965, another Mukherjee Committee in 1966, Jangalwala Committee in 1967, Kartan Singh Committee gave their recommendations in 1973, the Srivastava Committee was framed in 1977. So, we will be discussing all these committees in much details one by one. The Bhor Committee 1946, this committee is known as the Health Survey and Development Committee. It was appointed under the chairmanship of Sir Joseph Bhor in 1943 and submitted its report in 1946. It was the most comprehensive studied report and made from the micro level. There were two major objectives: to review the health situation and health organization in British India and to recommend the future development of Indian health system. Some of the major recommendations of this committee include the integration of preventive and curative health care services at all administrative level, the development of the primary health center PHCs in two stages. Number one, the short-term measure, one PHC for 40,000 population, and each PHC is to be manned by 2 doctors, 1 nurse, 4 nurses, 4 midwives, 4 trained DIs, 2 sanitary inspectors, 2 health assistants, 1 pharmacist and 15 class 4 staff. The secondary health care was also envisaged to provide the support and supervise functioning of PHCs. Number 2 is the long-term program 3 million plan of setting up a primary health unit with 75 bedded hospital for each 10,000 to 20,000 population and secondary unit with the 650 bedded hospital around the district hospital with 2,500 beds. As much medical relief and preventive health care as possible should be provided to the vast rural population of the country. The health services should provide all the consultant laboratories and the institutional facility for the proper diagnosis and treatment, and health program must lay the emphasis on the preventive work. All diagnosis and treatment services should be available in the public health facilities. Major changes in the medical education, which include 3-month training in preventive and social medicine to prepare the social physicians. Suitable housing, safe drinking water and sanitary surroundings. This committee was instrumental in bringing about public health reforms related to peripheral health center in India. Though most of the recommendations were not implemented at the time, the committee was a trigger to the reforms that followed. It required the implementation of structural changes in the then health system, and had they been implemented, they would have radically altered the healthcare access and the health status of Indian masses. The Mudaliar Committee 1962. After India's independence, the first 2 decades were mainly spent on managing and fighting the rampant epidemics like malaria, cholera and smallpox. It was also realized that major resources of the public health services have been spent only in the urban areas, while maximum population reside in the rural areas. Also, the recommendation of the Board Committee could not be implemented in real sense. For this, the Government of India appointed Health Survey and Planning Committee under A.L. Mudliar in 1959. The then Minister of Health said that the principle enunciated by the Board Committee are as valid today as they were at that time. And now 12 years of development necessitate today a resurvey of the whole field of the health. The main objectives of the Mudliar Committee report is to make the evaluation in the field of medical relief and public health since the submission of Board Committee report, to review the first and the second 5-year plan health projects and to make recommendations for the development and expansion of health services. The main recommendation of the Mudliar Committee included the provision of 1 PHC per 40,000 population. The staffing pattern of earlier or existing PHC should be upgraded as per the Board Committee recommendation. Strengthening of the subdivision and district hospital after the PHCs. At least 1 bed per 1,000 and 1 doctor per 3,000 population, and at least 150-bed basic hospital for each subdivision. There should be 1 500-bed district health and 1 medical college per 5 million population. No integration of the system of medicine. Central government should control communicable diseases. The All India Health Services should be created to replace the erstwhile Indian Medical Services. Chadha Committee 1963. The Government of India has appointed another committee in 1963 under the chairmanship of Dr. M.S. Chadha to advise about the necessary arrangements for the maintenance phase of the National Malaria Eradication Program (NMEP). The objectives of this program are to give the details of requirement related to the public health center, their planning, the necessary priority required as per the need of National Malaria Eradication Program maintenance phase, and to analyze the staffing pattern required for PHCs and the manner in which technical and supervisory staff of NMEP should be utilized after the eradication of malaria. Some of the basic recommendations of this committee are the vigilance operations in respect of NMEP should be the responsibility of General Health Services. The basic unit to have the effective control over communicable diseases and provide preventive health care. The basic health worker should be there per 10,000 population and should be redefined as the MPW, who will have to do the additional duties of collection of vital statistics and the filing. A medical officer trained in malaria is required to assist the district health officer, who also work as a district epidemiological officer, and investigate the cases, supervise the program, and take remedial action under the supervision of DHO. The family planning health assistant should supervise 3-4 MPWs. To establish the medical institution, particularly the dispensaries and PHCs planned during the third 5-year plan. Mukherjee Committee 1965. The recommendation of the Chadha Committee were impracticable because the basic health workers with their multiple functions could not do justice either to malaria work or to the family planning work. As a result, both the program, that is malaria and family planning program, suffered largely. The Mukherjee Committee was appointed to review the performance in the area of family planning program. The recommendations of the Mukherjee Committee include to dealing the malaria activities from the family planning program and separate staff for the family planning program. Separate family planning cell at the state health directorate level, which would work as an executive agency for the implementation of family planning programs. This family planning cell at the state would be looked after by a joint director and receive all the support from the other officials in the implementation of the family planning program. The family planning assistant were to undertake family planning duties only. The basic health workers were to be utilized for the purpose other than the family planning. The recommendations are: number 1, one basic health worker for 10,000 populations in normal areas, but in difficult and sparsely distributed population, the number of health workers may be increased proportionately. A health inspector for the 4 basic health workers. the existing sanitary inspector should focus more on the environmental sanitation. Leave and a training reserve of 5% of the total basic health worker should be provided. The technical staff, such as the doctors, should be relieved of the administrative work. A medical officer should be dedicated only in the National Malaria Eradication Program, that is NMEP. The district level health organization should be gradually strengthened to adequately staffed, and they should be headed by a chief medical health officer. There is a need for strengthening the PHED for preventive health care at the district level. A medical superintendent for the district hospital should be provided. A proper building for the office and the residence of the public health center and the central level should be given. An adequate emphasis on the continuing training to the medical as well as to the paramedical staff should be given attention. Jangalwala Committee 1967, it's also known as the Committee on Integration of the Health Services, and it was appointed in 1964 under the chairmanship of Dr. N. Jangalwala to assess the various problems related to integration of the health services, abolition of private practices by doctors in government services, and the service conditions of the doctor. The recommendation of this committee included the integration of health services, organizations, and personnel from top to bottom level. It includes the interdependence between central, state, and the local government in health matters, including the program. It also includes the district level health organization should be strengthened properly to undertake the comprehensive health work on the regionalized basis. A public health center is a paramount institution and medical officer must be in the complete administrative control. It also suggested the integration of the services will not be effective unless all medical officers are brought in one cadre and the improvement in their services condition is made. The common seniority and the equal pay for equal work and special pay for special work was also suggested. Abolition of the private practices by the government doctor was another recommendation of this committee. The Kartar Singh Committee, this is also known as the Committee on the Multi-Purpose Workers, MPWs, under Health and the Family Planning Program. The main objectives of this committee was the structure for the integrated services at the peripheral and the supervisory level need to be made, the feasibility of the MPWs and their training requirement, the utilization of the mobile service unit set up under Family Planning Program for integrated medical, public health and family planning services operation in the field. The recommendation of this committee include the various categories of the peripheral workers should be integrated into a single cadre of MPWs, male as well as female. The erstwhile A&M were to be converted into MPWs, female and basic health workers, malaria surveillance workers, vaccinators, health education assistants, and the family planning health assistant to be replaced by MPWs. The work of 3-4 male and female MPWs was to be supervised by one health supervisor. The existing LHVs were to be converted into female health supervisor. One PHC should cover a population of 50,000 and it should have at least 2 doctors. A PHC should be divided into 16 sub-centers, one for 3,000 to 3,500 population, and each sub-center to be staffed by a male and a female health worker. The doctor in charge of the PHC should have the overall charge of all the supervisors. The training of the female health worker in the 5-year plan and the number of A&M training should be increased, particularly where the state has acute shortage. Srivastav Committee. The Ministry of Health and the Family Planning, Government of India has set up a group on medical education and support manpower in 1974 under the chairmanship of Dr. J.B. Srivastav. The group submitted its report in April 1975 and its main objective were to devise the suitable curriculum for training of the health assistant conversant with the basic medical aid so that they can serve as a link between the qualified medical practitioners and the MPWs. Next, to suggest the steps for improving the existing medical educational processes, and then to make any other suggestions to realize the above objectives and related matters. Some of the important recommendations of the Srivastava Committee are the creation of para-professionals and semi-professional health workers from within the community. That is, for example, teachers or postmaster to provide the simple, promotive, preventive and curative health services to the community. Establishment of the three cadre of health workers, namely MPWs and health assistant between the community level workers and doctors at PHC. Development of a referral service complex by establishing proper linkage between the PHCs and higher level referral centers. Establishment of a Medical and the Health Education Commission for planning and implementing the reforms on the lines of UGC. Involvement of the medical colleges in the healthcare service delivery of selected PHCs with the objective of reorienting education to the need of rural people. And reorientation of MPWs engaged in the control of various communicable disease program into uni-purpose worker. The recommendation of the committee were accepted by the Government of India in 1977, which led to the launch of the Rural Health Scheme. The National Health Policy 1983, the Constitution of India directs the state to raise the level of nutrition and the standard of living of its people and the improvement of public health among its primary duties, securing the health and strength of the worker, men and women and children. To achieve this, the country should have a broad policy and detailed guidelines, but our country did not have any policy until 1983. The National Health Policy 1983 consists of 20 paras and an appendix setting the goals for health and the family welfare programs. India is also a signatory of the Alma-Ata Conference of WHO, which committed to attain the goal of health for all by the year 2000 AD through the universal provision of comprehensive primary healthcare services. The attainment of this goal requires a thorough overhauling of the existing approaches to the education and training of medical and health personnel and the recognition of health service infrastructure. It is also necessary to secure the complete integration of all plans for health and the human development with the overall socio-economic development process. The salient features of the National Health Policy are: it emphasizes on the preventive, promotive and rehabilitative healthcare approach and provision of a universal and comprehensive primary health. It involved the private practitioners and the NGOs to expand the coverage of and access to the services. It aimed for the decentralized healthcare, low-cost deprofessionalization, and community participation and establish a referral system. It meant for establishing a nationwide chain of epidemiological stations. It recommended to encourage the private investment in the health sector to reduce the government burden. And it emphasized on the need of national population policy for stabilizing the population because it's most important component. Changes in the curriculum and training of the medical and the health professionals and provide guidelines for the production of health personnel on the basis of manpower requirement. Program to provide the mental health care as well as the medical care and physical and social rehabilitation of mentally retarded, deaf, blind, physically disabled, infirm and the aged. Priority to the people residing in the tribal, hill and the backward areas. Doctors should be given compensatory non-practice allowance. And integrating the indigenous and the other system of medicines. The different priorities areas identified by the National Health Policy 1983 are identified as: number 1, the nutrition, and then next is the prevention of the food adulteration, then taking care of the water supply and sanitation. Environmental protection is another. Then immunization programs are given due importance. The maternal and child health services will be taken care of. The school health programs and the occupational health services. The health information system for the appropriate decision making and the program planning should be given due attention. There is more industries to produce the quality drugs, vaccines and biomedical equipments, etc., with a special reference to the diseases like malaria, tuberculosis, leprosy, blindness, etc. There should be a production of the indigenous and the herbal medicines, which should be encouraged. Then next point which is to be taken care of is the effective health insurance schemes should be developed at state and at the central level. The existing health legislation need to be reviewed and making them suitable for the better delivery of the healthcare services. There should be a intersectoral coordination of the various efforts and the timely monitoring and review of the progress of these programs. The National Health Policy 1983 may be observed that most of the goals set for the 1990 and 2000, except the death rate and a few vaccination, could not be achieved. The reason may be over-ambitious goals, inefficiency in implementation, and routine monitoring and evaluation of the program. Besides, the emphasis of the NHP 1983 was also on the preventive and promotive health care, and the suggestions for involvement of private players in the curative health was given. The health depends on many factors such as the education, economy, nutrition, occupation, environmental conditions, agriculture, land reforms, and the social structure. Unfortunately, the National Health Policy narrows down its direction to only provisions for the physical infrastructure of health. This policy has identified priority areas, but not much work is being done. The policy advocates for the community participation, but it fails to ensure their participation as most of them still prefer to choose private health facilities. Decentralized planning, implementation, and control are not much emphasized in the National Health Policy, which may lead to the poor acceptance of the program at the state and community level. The National Health Policy 2002. The Government of India has revisited its previous health policy and came up with a new policy in 2002. The aim was to achieve an acceptable standard of good health, decentralization of the health facility, equitable access, increase in the investment, identification of national problems like malaria, tuberculosis, blindness, etc. The main objectives of this are acceptable standard of good health of the Indian population, decentralizing the public health system by upgrading the infrastructure in existing institutions, equitable access to the health services, enhancing contribution of private sector on affordable prices, emphasizing rational use of drugs, increasing access to traditional medicines. The major goals to be achieved by the National Health Policy 2002 can be broadly classified as reducing the morbidity and mortality, increasing the public health facilities, increasing public health spending. The policy prescriptions of National Health Policy 2002 include the financial resources, where the health sector investment is to increase to 6% of the GDP by the year 2010. The existing 15% of the central government contribution is to be raised to 25% by 2010. The National Health Program is to optimize the utilization of public health infrastructure at primary level, gradual convergence of all the health programs under a single field administration. The vertical program for the control of major diseases to be continued till achievement of the moderate level of prevalence, and a scientific designing of the public health projects suited to the local situation. It also emphasized on the public health infrastructure, where the revival of public health by providing some essential drugs through decentralized health system. It includes the frequent in-service training to the health personnel. It involves the increase in public expenditure by reasonable user charges. It also emphasized on extending the public health services, expanding the allopathic, Ayurvedic, and homeopathic practitioners as well as trained paramedical manpower of allopathic to the underserved areas through simplified recruitment procedure for contract employment. It also involved the role of local self-government institution, where implementation of the health program through local self-government institution will be done by 2005. It highlights the decentralization of the implementation of program including mental health services for reducing the more common categories of disorders. It also focused on the education of the health educators, setting up of a medical grant commission to address the uneven distribution of medical and dental college, to highlight the need-based and skill-oriented syllabus and more practical training to the doctors. The norms for the healthcare professionals includes the Indian Medical Council Act and the Indian Nursing Council Act provides statutory norms for the doctors and the nurses which should be introduced urgently to raise the proportion of postgraduate seats. For the nursing professionals, the need for an improvement in the ratio of nurses and the doctors, the need for training courses for the super specialty nurses required for tertiary care institution. The IEC component of the policy include the need of an IEC policy for maximizing the dissemination of the information, the priority to the school health program which aims at preventive and promotive health care. The health research was also focused in this policy. The role of the private sector, role of civil society was also highlighted, and the women health was given a due focus. In addition to this, the policy also laid emphasis on the National Disease Surveillance Network from the lowest level of public health administration to the central government and a contemporary code of ethics to be notified and implemented to ensure that common patient is not subjected to irrational or profit-driven medical regimens. Now let's summarize, students, this module which we have learned so far. We have discussed the various health policies in details, that is the health policy in 2002 and health policy in 1983. And before that, we discussed the different committees which were formed and they gave their different recommendations towards the formulation of an health policy for the citizens of India. We have studied all the committee's recommendations made since 1946 to 1975. And on those basis, we have studied the final health policies formulated in 1983 and 2002. All these details in these two policies we have discussed in much details in these modules. So, national health policies have been discussed with their evolution and development and the provisions by the policies to its citizen. Thank you.